Welcome y'all. Our next segment is the Symposium on Tropical Infections. May I now cordially invite the chairpersons, Dr. Vimal Siruluwatake and Dr. Nilanka Pereira, to introduce the speakers.
Good morning and welcome to the first symposium of annual academic sessions of Ceylon College of Internal Medicine. And it's going to be on tropical infections. The topic of the symposium is tropical infections. And there are three very important talks line up here. And together with my co-chair, Dr. Nilanka Pereira, I am Dr. Vimal Siruluwatake, both are specialists in internal medicine. Would like to welcome all of you to this very important symposium. The first talk is on acute fevers, going to be delivered by Dr. Jyotirmoy Pal. He is the professor of medicine and Department of Internal Medicine, College of Medicine and Sagadutta Medical College. He is the Dean, Indian College of Physicians and President-elect Association of Physicians of India. Can I call upon all the three speakers to the stage? Professor Panduka Karunanayake and Professor
Nandini Chatterjee.
Yeah, Professor.
Could we also invite Dr. Nandini Chatterjee to the stage?
Good morning, everybody. I am really delighted to be invited in the 7th annual conference of Sri Lanka College of Internal Medicine along with Association of Physicians of India. So, basically, India, Sri Lanka, Nepal all belongs to the zone that is called the tropical zone. And fever is one of the most common challenging issue to the physicians practicing in this zone. So, from that basket, first I will explain you what is the approach to an acute fever in the tropics. In his famous book, Origin of Species, Charles Darwin mentioned three terminology. One is the struggle for existence, one is the survival of the fittest, and natural selection. And basically, history of mankind in the earth basically governed by the repeated history of different epidemic and pandemic. If we go back to the history, 336 before Christ, Alexander the Great, you know in the history, he came from Greece to India and defeated the powerful king Puru in the Punjab province. But on the way returning back to Greece, he died from the fever, tropical fever, possibly it was cerebral malaria. So tropical fever is so dreadful that Alexander the Great surrendered to a simple mosquito-borne diseases. In 2023, again, the tropical fever is our focus, is our challenge, because the emergence and re-emergence of different tropical diseases, and this happened due to the global warming, climatic change, and international travel. So tropical fever is not the challenge of the tropical countries. Now it is becoming a challenge in the temperate countries also. So what is tropical fever? By definition, it is basically infection that is prevalent or unique in the tropical or subtropical region of the world. So that means this is more diseases that are more common present with the fever in these tropical countries. And because of the hot and humid climate in this area, excessive rainfall, excessive population, poverty, lack of medical care. So there is in one side, there is a growth of the organism, growth of the vector. At the other end, there is a lack of proper medical care, proper diagnosis. That is why sometimes, or not the sometimes, frequently the tropical fever is become a threat to the mankind and a very big challenge for the physician to encounter. So tropical fever, basically we can categorize in the three categories. One are few due to the typical tropical infections such as dengue, malaria, leptospirosis, or some of the infection are prevalent both in tropical and temperate region, but more prevalent in the tropical regions such as tuberculosis, HIV, influenza, and there are some of the tropical fever due to non-infectious diseases also. So three category basis of the tropical fever. And domains of the tropical fever, this knowledge is very important. Basically, these are the different either vector-borne or food-borne or water-borne. So history or knowledge, what are the diseases is spread by the vectors, what are the diseases spread by the food, because the population in the tropical countries are frequently coming in contact of the different polluted water or coming in contact due to the occupation or due to the proper lack of hygiene to the different vectors, and people are infected with the particular diseases. So if you have the proper knowledge of the vector, what are the vectors transmit the disease, you can have some of the idea what the disease the people have, because in the tropical region, because of the lack of proper medical care, the economic problem, frequently we have to give the empirical therapy rather than the appropriate, quick and appropriate diagnosis and appropriate therapy. So what are the common infection? When we are with the physician in the tropical countries, we are facing a patient came in your clinic with a fever. What are the most common? Because infection may be so many, but here in 90 to 90% cases, you will deal with the following infection, such as dengue, malaria, scurf typhus, enteric fever, leptospira, chikungunya, leishmaniasis, Japanese bee encephalitis. These are the most common infection that will cover more than 90 to 95% of the infection when the patient with fever will in the tropical region will come to your clinic. So before going to the approach, first we have to be very clear about the two definitions. One is the acute febrile illness and another acute undifferentiated fever. Acute febrile illness means very simple. Patient have a fever of more than 38 degrees centigrade or higher and persisting for 2 to 7 days. This is the acute febrile illness. So usually patient come to your clinic, OPD or emergency with acute febrile illness. So now the terminology acute undifferentiated fever. That means patient came with acute febrile illness, but you cannot localize any particular system involvement. Suppose you are not getting any findings in the chest, lung, heart, wherever. It is not pneumonia. So that is called acute undifferentiated fever, because you have not localized any system, any particular system that is involved. So these are two terminologies very important when we are dealing a patient with fever in the particular topics. Now the clinical challenges, what are the clinical challenges? Clinical challenges are basically most of the infection in the tropics are asymptomatic or subclinical infection. So that is why we often miss many of the infection, and these patients become a source of spreading infection from one person to another person. Overlapping symptom. Nowadays, due to some immune changes, we are getting malaria, which is classical to have chills and rigor. We are getting the low-grade or persistent fever even in the malaria. This is the changing profile. Even the vivax malaria are now presenting with like a falciparum malaria with the renal failure or hepatic failure. So changing profile, overlapping syndrome, mixed syndrome, dengue and malaria in the same patient is often possible. So these are the challenges what the physicians of the tropical countries faces. That is why either often we have a underdiagnosis or we have a overdiagnosis that poses a threat to the patients. So, for the common three factor for the diagnosis of the acute febrile illness is the 3-step: take proper history and go for the clinical examination and go for the appropriate laboratory investigations. So, regarding the history, so these are the few histories are very important, particularly whether you have any particularly systemic involvement, you have a cough, fever, burning sensation, or you are on a chronic drug therapy, or particularly very travel to endemic zone. Suppose you are in the Bihar, not Bihar, there is a very endemic zone for the Kala Jar. So if a patient come from North Bihar to Kolkata or to Mumbai, so you should suspect the patient may suffer from the Kala Jar. And exposure to the vectors, this is very important. In the slum areas, there is a lot of mosquito, particularly after the rainy season. So whether you are exposed, you have not used the mosquito net. So exposure to the vectors, that is important to identify what type of fever, what type of infection may be transmitted to you. High risk behavior, whether suppose a truck driver, he has a contact with the prostitute, this is a high risk behavior, or a intravenous drug user, that the infective endocarditis or hepatitis B, C, or HIV can be transmitted. So these are the few important history that will help you to identify the diseases and guide you for the empirical therapy. So on the basis of, because I told previously in the challenges of the tropical physicians are that appropriate diagnostic facilities are often not available. All of us will not work in the medical college environment or in a medical university. So most of the physicians will work in a situation, in rural or a subdivisional situation where the appropriate investigation in appropriate time is often lacking. So physicians have to depend on the empirical therapy. So, for the tropical physicians should depend on the more a syndromic approach. What is syndromic approach? That we are coming. So, syndromic approach means based on some of the signs and symptoms, you categorize the patient. That will help you to minimize the differential diagnosis. What are the categories? Categorizes like this, I have mentioned here. One is acute encephalitis syndrome. Suppose patient came with fever with confusion, with memory loss, with convulsion, or fever with rash, fever with hepatosplenomegaly, fever with lymphadenopathy, fever with acute kidney injury, fever with jaundice, fever with hepatorenal syndrome, fever with arthalgia, fever with multi-organ involvement. So first to categorize the patient according to signs of symptom. That will minimize your differential diagnosis, so that if you want to give the empirical antibiotic, that should be more close to your actual diagnosis. This is the basis of the syndromic approach. Now we are coming to one index case. How on the basis of syndromic approach you can give the justifiable treatment to the patient. One 50 years male in India developed fever with moderate grade chill, body ache, headache, nausea, vomiting, abdominal discomfort. So basically now patient has came with acute febrile illness, and you have not identified any particular systemic involvement, but that is called the localizing sign. Urine output normal, no jaundice, no hepatosplenomegaly. That means patient came with acute febrile illness. As the patient have no localizing sign, so you have stamped this patient has a acute undifferentiated fever. Now what will be your approach? So I told at the beginning, you take the proper history of the patients, from where the patient has came, what type of vector, with the vector patient may be exposed, and duration of the fever, jaundice, abdominal pain, headache, vomiting, particularly the geographic location of the patient, from where the patient has come, or is there any recent outbreak of the disease? Suppose in the India, in the some of the part now at present, the dengue outbreak in Kolkata is going on. So whether the patient are from that area, that can give you some clue the what type of infection. Very important, the incubation period. What is the last possible day of exposure, and when the patient's fever comes, there is a duration. This is the possible incubation period, because the incubation period vary from disease to disease, from virus and bacteria to another virus or bacteria. So appropriate duration of illness, some idea, and travel history, occupational history can give you some clue what type of infection patient, tropical infection patient may have. So I told the knowledge of the incubation period, possible day of the last exposure to the day of onset of the disease. If the, for one example I am giving, is the duration is possibly less than 10 days, that the arboviral infection is more common, like the dengue, chikungunya. If it is more than 1 month, chance of kalaja or brucellosis is more. This is the knowledge of the incubation. I have time is short, so I have given some example how the incubation period knowledge can help you for the empirical therapy. Type of exposure, several times I mentioned that whether patient is exposed. If the patient work in agriculture field, there is chance of scarf typhus become more. So what type of occupational history and possible type of exposure is very important to formulate the strategy of the fever. Next is coming the pattern of fever. What type of fever? If the patient have high grade fever, patient more chance with the dengue, malaria. If the patient has biphasic fever, chance is more with dengue and leptospirosis. Periodicity more common with malaria. So on the basis of, at the emergency, patient has came with acute undifferentiated fever. So your duty, tropical physicians, first you do the RDT for the malaria, because within 10 minutes you will get the result that whether patient is suffering from malaria or not. Then you send the blood for the ELISA for dengue NSA1. This is the two very important differential diagnosis you have to exclude or have to establish at the emergency. So the differential diagnosis what in your hand is, one is dengue, malaria, different viral infections, scarf typhus, leptospira. These are the 5-6 common infection that is in your hand. And dengue, malaria, you try to exclude or stamp at the time of emergency, sending the blood for the RDT and ELISA. So dengue and malaria probably you have excluded, and now you observe whether there is any red flag signs for the patient. Because the red flag sign can appear for any of the tropical infection. If the patient have red flag signs, suppose patient have repeated vomiting, patient have some jaundice, patient have some confusion, you immediately hospitalize the patient. Otherwise, if patient have no red flag sign, malaria is negative, you have sent the blood for NSA1 for dengue, now you observe the patient clinically for 72 hours. Because within 72, after 72 hours, most of the infections, systemic signs and symptoms, that is, I am telling the localizing signs and symptoms, usually appear after 72 hours. So up to 72 hours, give only paracetamol, no antibiotic, and observe for any red flag sign. If there is any red flag sign, admit the patient, or you observe and ask the patient to inform you daily basis and to come at least physically after 72 hours, when you have opportunity to examine the every system of the patient and try to diagnose whether any particular system is involved, because by that way you can categorize the patient in your syndromic approach that I have mentioned. So 4th day patient, after 72 hours, patient as you ordered came to your clinic. You have observed the patient have conjunctival hemorrhage and patient has maculopapular rash on the body. This is the 4th day you have observed two important signs. One is conjunctival hemorrhage, one is the maculopapular rash. So that means on the 4th day you place the patient in the category of syndromic approach, that is fever with rash. So how will approach the fever with rash? Here important is you observe the distribution of the rash and appearance of rash according to the day of onset of the illness and characteristics of the rash. So you clinically observe 3 important points. Why this is important? See, this is the distribution of rash. According to the distribution of rash, I am big list. I am 1 or 2 example I am giving. Suppose patient has purpuric rash. It can be malaria, dengue and leptospirosis. If it is conjunctival rash, patient can have dengue and leptospirosis. So distribution pattern of rash is helpful for the syndromic approach. Now the day of appearance of the rash, from the day of fever, and when the rash appeared, suppose rash appeared on the 3rd day of fever, there is more chance of smallpox. That is now eradicated. If the rash appeared on the 5th day, more chance of scarf typhus. So onset of fever and day of appearance of the rash, this gap is very important for knowledge about the possible infection. This is the dengue rash. This is the picture. So scarf typhus is not coming, varicella vesicular rash. So, fourth day you categorize the patient as a fever with rash syndromic approach, and the three important points you have observed to have some idea what type of infection patient came. Again, on seventh day of the patient developed jaundice, and on examination you have observed the patient have hepatosplenomegaly, and 10th day patient developed acute kidney injury. So that means patient of India, patient from Mumbai, worked in a actual occupation was as a labor, stay in a slum area, developed fever. Initially, first day was no localizing sign, that means acute undifferentiated fever. Fourth day, patient with fever with rash. And seventh day, that is in the second week, patient now syndromic approaches, patient with fever with jaundice and acute kidney injury. So this is the importance of the syndromic approach, how it can be helpful for the tropical physicians. So if we can have some idea about the fever with hepatosplenomegaly in a second week, your differential diagnosis can be malaria, enteric fever, hepatitis or leptospirosis. So this is the way how the syndromic approach can cut short your differential diagnosis. So now another entity is the fever with jaundice. So fever with jaundice, left-sided are the diseases that can appear the patient with fever with jaundice. Here some of the important issue we could remember. The fever, if the fever subsides with the appearance of the jaundice, possible diagnosis is hepatitis. But here it was not the case. But if the fever persists even after appearance of the jaundice, possible diagnosis may be in the tropics, either malaria, sepsis or leptospirosis. I am not enumerate all the lines here. This is the very important clues you have to remember when the patient come with fever with jaundice. Remember in case of dengue, scalp typhus, usually there is some elevation of the enzyme, not the frank jaundice or hepatic liver failure. But in case of leptospira and malaria, patient can present with jaundice even with the acute liver failure. Now, third entity, in the second week, this patient have fever with renal failure. These are the diseases I mentioned in the left-hand side, that that possibility of the fever with renal failure. And you remember that in malaria, usually patient with oliguric renal failure, but leptospira patient present usually with non-oliguric renal failure. So, in the second week, the differential diagnosis that you have, one is the dengue, malaria, different viral infections, scalp typhus, and leptospirosis. Malaria you have excluded at the emergency by RDT. NS1 you sent at the first day, so second day you got the report patient NS1 was non-reactive, so first two infection was excluded. Here the 10th day patient have fever with jaundice with non-oliguric renal failure. In scalp typhus, usually patient does not develop so much conjunctival hemorrhage with purpuric rash, with jaundice and renal failure. Scalp typhus, usually patient develop some eschar rather than purpuric spat, and patient have asymptomatic or mildly symptomatic only enzyme elevation. But here the patient have rash, there is a purpuric rash with jaundice, with non-oliguric renal failure, with conjunctival hemorrhage and with hepatosplenomegaly. So here more likely differential diagnosis among this list was leptospirosis, and the fever definitely persisted even after appearance of the jaundice. So you have sent the appropriate investigation. RDT and NS1 was sent before. So now you have sent the biochemical investigation. The bilirubin that was came to 14 milligram person and SGBT 87. You observe here SGBT elevation is not so high or not proportionate to the bilirubin elevation, because in leptospira the two way the bilirubin increases, one by the hepatic damage, another by the hemolysis. That is why bilirubin elevation is more than the enzyme elevation. Urea creatinine was high, creatinine was 2.1 and urea was 112, and other appropriate tests, that is culture, X-ray, other you have sent. Molecular test, you have done the X-ray, ultrasound, CT, MRI, and you have sent different IgM or different antigen or antibody testing for the different infection. Here, the IgM for leptospira found to be positive. So this patient is found to be a case of leptospira. This is called the syndromic approach. That means you have categorized the patient according to the syndrome. That has helped you to minimize the battery of investigation, and you, even if you do not have the laboratory facility, on the basis of knowledge, clinical approach, syndromic approach, you can have some idea, because from the clinical symptoms, we have already, before going for the investigation, we have some impression that patient may suffer from leptospira, because patient has from the slum area, patient is a laborer, stay in a congested area, patient present with fever, then develop conjunctival hemorrhage, purpuritis, then jaundice, hepatosplenomegaly, and non-oligonucleotide renal failure. So this is the very characteristics for the leptospira. So even if you do not have the facility for the investigation, you can empirically diagnose the patient of leptospira. Anyhow, with the facility of investigation, you have pinpoint the patient has stamped the patient has case of febrile illness. So in summary, I am coming. The first patient will come with acute febrile illness. You try to get any localizing findings, suppose burning sensation or pneumonia, then you treat accordingly. If there is no localizing signs, your diagnosis is acute undifferentiated fever. Malaria you exclude at the emergency by RDT. Send blood for the dengue NS1 that may come usually nowadays by 24 hours. If you observe the red flag sign, you admit the patient or ask the patient to come after 72 hours and every day to inform the physicians about its well-being. And by these 3 days, you give only paracetamol and no antibiotic needed in the first 3 days. After 72 hours, you observe for the any system involvement, such as rash, jaundice, renal involvement, rectal rigidity, neurological symptoms, arthalgia, hepatosplenomegaly, and put the patient according to the syndromic approach. If after third day, 72 hours, even you get some, you can put the patient in some of the syndromic approaches, and you think the patient should be given antibiotic. In tropical countries, the recommendation is use doxycycline or ceftriaxone or both combination, because these two antibiotics can cover most of the tropical infection. So this is the syndromic approach or best empirical choice for the treating the tropical disease in a tropics when the appropriate investigation facility is not available. If you get the relevant investigation facility, send the relevant investigation and treat accordingly. Even after giving the getting the report from the investigation and the fever not resolved by 3 weeks, you put the patient category as a pyrexia of unknown origin. Some of the authority now put as a 2 weeks as a mark for the diagnosis for the PO. And this PO part will be dealt by my second speaker, Professor Nandini Chatterjee. So the tropical physician, we have two challenge. One is the clinical challenge that lead to diagnostic challenge and therapeutic challenge. So I hope the physicians of the tropical countries with the knowledge of this tropical fever, particularly we have to bank on the empirical therapy. So syndromic approach is very much important, very much, particularly the students who are present here, you be more knowledgeable for the syndromic approach that can help you in the most of the part of the tropical countries where the appropriate investigation facility is not available. So we have published a book on tropical fever. I hope this is available in Amazon. You can read it if you like. I am very much thankful to be invited in a country of my favorite cricketer. Thank you.
So thank you, Dr. Jyotirmoy Pal, for that interesting approach to acute fevers. So we move on to prolonged fevers as a second talk. The talk will be delivered by Dr. Nandini Chatterjee. She's a professor of medicine in the Institute of Postgraduate Medicine, Education and Research, SSKM Hospital, Kolkata, India. Over to you, Dr. Chatterjee.
Thank you very much. It is an honor to be invited to Sri Lanka, and I'm thankful for the organizing team. Today, I will be speaking on the issue of prolonged fevers in the tropics. As we all have the experience that undiagnosed prolonged fever is a physician's nightmare. In the South Asian regions, various series of cases have demonstrated that nearly half of the cases are due to various infections, which are followed by malignancies and connective tissue disorders. Drug fevers are implicated in a small percentage of cases. What is to be remembered is that 10 to 15% of pyrexia of unknown origin remains undiagnosed. So, in order to diagnose such cases, we need to be systematic in our approach, and that is what I will be discussing today. The approach heavily relies on the potential diagnostic clue. This potential diagnostic clue comes from a meticulous history taking, followed by examination of the various organ systems of the body. And if all these fail to give you some direction, then we have to rely on investigations. Now, let us begin with an illustrative case of a 65-year-old male farmer from the rural areas of Bardhaman in India. He was a chronic smoker, did not have diabetes or hypertension, but he was suffering from an low-grade intermittent fever for the last 2 months. And he had weakness and quite an amount of weight loss. Now, all of us have encountered such patients in our clinical practice. And the problem is that with such non-specific complaints, there is a huge list of causes which can all lead to prolonged fever. Of them, as we all know, the infectious causes may be caused by various viruses, bacteria, parasites, even fungi. There may be non-specific infections involving the heart or the bones, or there may be some collection of pus hidden somewhere in the body which may lead to such prolonged fevers. We should not also forget a huge group of disorders, the connective tissue disorders, the autoinflammatory syndromes, and various malignancies which can come to you in the form of fever. So, where to begin? As I have stated already, we always begin with history. So, first to take note is what is the age and gender of our patient, what is his or her occupation, living conditions. One important thing is what is the local disease prevalence. Some disease may be prevalent more in the part of India where I come from, whereas something else may be prevalent in Sri Lanka. So, knowledge about local disease prevalence is very, very important when you are considering such cases. What is the pattern of fever? Is it continuous or intermittent or remittent? What is the intensity? Is it associated with rigor or night sweats? Is there significant weight loss? Is your patient pregnant? A very important aspect of history is what is the associated symptom along with the fever. This associated symptom will give you the direction of the organ system which is primarily being involved in this case of fever. Is the patient also having some comorbidities which you should be careful about? Is he suffering from some chronic disease, chronic drug therapy is there or not? Has the person recently traveled to some endemic zone? Does he have pets? Is there evidence of vector exposure or high-risk behavior? So all these things you need to ask the patient because the patient may not volunteer always. So it is the duty of the physician to specifically ask about various aspects when you want to find a potential diagnostic clue from history. Now, after the history, you need to examine each and every organ meticulously, not to forget also the general examination, which may reveal some pallor or jaundice or lymph nodes hidden somewhere in the neck or the axilla. Is there thyromegaly? Is there any rash which may give you a clue? Evidence of effusions, organomegalies, any neurodeficit? Evidence of some hidden mucosal ulcer, which you will not find unless you ask the patient to open the mouth. Dr. Pal has described in great detail the importance of a syndromic approach in fever. But we must remember that the syndromes which are common in acute febrile illness is different from the syndromes of the prolonged fevers or the pyrexia of unknown origin. So, organomegaly, lymph nodes, some specific types of rashes, effusions, or certain neurodeficits need to be searched for in case of PUO patients. I will not go into the details of the causes, but again, to repeat somewhat what Sir has enumerated, is that various different etiologies present with different syndromes. So let's come back to our case. So that gentleman, when examined, was found to have a low BMI. His pulse was 94 per minute, equally palpable in all his limbs. His blood pressure was 90/60 with a postural drop. He had a mild temperature at that time, and also he had some hyperpigmentation in the oral mucosa. When the different systems were examined, we found that there were scattered crepes in his lungs. However, examination of the cardiovascular, nervous, and GI system was normal. So to summarize, the history and examination found in our patient of fever for 2 months, there were subtle clues, not very hard findings, but we would have to progress with that, and now is the time to discuss some of the investigations that you have to do in such patients. The investigations can be divided in 3 strata. First is the group of obligatory investigations, which are included nowadays in the definition of pyrexia of unknown origin, and that is actually a big list, some of which may not be readily available in low resource settings. However, unless we get all of them negative, we cannot move on to the next step. So, as we all know, that we start out with the complete hemogram, the inflammatory markers, the renal and the liver function tests, the electrolytes, and if we are suspecting an infection, we go for the microbiological profiles involving microscopy. The second point, that is culture, is extremely important because unless you have excluded any infection through culture, you cannot move on to the other group of etiological possibilities. Serological tests are available for various infections. However, they may not be available for some and also not so in the rural setups. But anyway, these are included in our literature and we have to write about that. I do not know whether PCR is available everywhere here, but in our tertiary medical centers, they are in India. I will have a discussion after that because sometimes you get obstructed by the non-availability of certain investigations. Culture can be done from blood, urine, or various body fluids. We also need to test if we have any effusions, we need to test those fluids. However, if you have excluded infections, you need to look outside, and now is the time to look for connective tissue disorder profiles. You also need to look for hematological malignancies and can do the protein electrophoresis. Radiologic investigations are very, very important, and you start with the humble chest X-ray and ultrasound, and if you find something abnormal in that, you may go on to do further imaging with CT scan. The echo or the MRI of vessels or Doppler study of vessels, all these are specific investigation to be done only when your clinical evaluation and the initial preliminary tests have given you a direction that we need to test those. You should not give a whole list of investigation from head to toe to the patient so that he or she may be in deep trouble financially. If all tests are non-contributory so far, then our hope lies in doing a PET scan, which is a non-invasive study and can give you a localization of potential infectious or inflammatory or neoplastic causes. From this PET scan, you can go on to do a culture and also do biopsy for histopathology. So after having enumerated the whole list of investigations that can be done in cases of prolonged fever, I come back to our gentleman. And in him, the initial investigations revealed a high ESR. Otherwise, the other tests were not very helpful. The workup continued, and we did serology, urine testing, and ECGs, which were normal. This is the chest X-ray of the patient. The chest X-ray of the patient reveals scattered opacities in both the lung fields. Having seen this chest X-ray, we went on to do the MUN2 and this sputum for tuberculosis, as well as culture sensitivity. Though they came out to be negative, the MUN2 was positive. Now, at this juncture, in our daily practice, whenever we get such chest X-rays, patient with fever for 2 months and with a MUN2 positivity, we tend to think of a particular disease. So the USG had also been done along with the chest X-ray as part of the routine imaging workup. It revealed bilaterally enlarged adrenal glands. I want to take the audience back to the examination of the patient, where we had found that the patient had a low BP and orthostatic hypotension. We had done a CCT of the abdomen because the USG had revealed such abnormalities, and that revealed that there were bilateral adrenal masses which were quite large. The left one was smaller than the right. We went on to do the cortisol and the ACTH levels, and which confirmed our suspicion of an adrenal insufficiency. Now, these happenings led the physician in control to think of these differential diagnoses. However, the first one being tuberculosis. He prescribed anti-tubercular therapy and oral steroid to this patient. The patient started to improve after receiving this, and he was discharged with a plan of regular follow-up with reports of his electrolytes and liver function test. The patient came after 15 days with a subsidence of fever. However, then he was lost to follow-up. When his course of ATD was finished, he started developing a recurrence of fever. At that time, he came to the tertiary care center saying that I have completed my medicine course. Why do I have fever now again? So now a second CT scan was done in that patient, and it was found that the enlarged adrenal glands were still present. They had not diminished in size, and they showed a peripheral enhancement. So now we have a patient who still has fever, who had gained some weight in the middle when he was on steroid and anti-tubercular therapy, but once all the medications had stopped, he had gone back to his initial state. Not so much, but again, the recurrence of fever had occurred. So, when you have such a situation, it is time that you now consider that we have to go for invasive investigations. Why I wanted to present this case is that in a case of fever, you start with the preliminary investigations, try out whether you can diagnose clinically, then you try out whether you can diagnose by only non-invasive tests, but there comes a time when you have to go for invasive tests to confirm the diagnosis. Also, the importance of this case is that whether empirical ATD or ATD on the basis of just clinical decision making is appropriate or not. So, biopsies can be done from various organs if you have localized them on your examination. But in this case, since it was the adrenals, we had to settle for a FNC from the adrenal mass. And this revealed the report of degenerating histoplasma capsulative organisms in a necrotic background. So our patient was a case of adrenal histoplasmosis who presented with Addison's disease in a competent person. Now, histoplasmosis of adrenals is not so uncommon, and this case demonstrates that even though adrenal insufficiency, low-grade fever, and opacities in the lung may make us believe that this is a case of tuberculosis in our settings, but we should not stop from thinking about other causes. Time is short, so I will quickly skim through the second case of a 20-year-old female who presented again with a prolonged fever and cough. On examination, she revealed crepitations more on the left lower zone of her lung, and other systemic examinations were non-contributory. Her investigations mainly revealed a raised total WBC count and a neutrophil ratio of 84%. There was some hypochromic microcytic anemia as well. The chest X-ray, it is a little hazy, showed some rounded opacities in the lower zone, left and right side both. The USG showed hepatomegaly, and the other investigations were non-contributory. Now, the potential diagnostic clue here is the chest X-ray and the taking into background the history of fever. We went for the sputum and the CT thorax. The CT thorax reveals opacities which are having a tendency to coalesce with hilar lymphadenopathy. We did a CT-guided FNC from the lung lesion, and it showed some organisms with branching filaments. Culture from the biopsy tissue revealed nocardiosis. So this was a very uncommon case, and that is why I wish to share it with you, which is another case with opacities in the lung and prolonged fever. However, I must not convey the message that we should ignore tuberculosis as a case of lung opacities, because always that should be the number one thing on your mind. So to sum up, diagnosis of prolonged fever is a challenge. Clinical signs and symptoms are often subtle or overlapping, and there are problems of cross-reactivity and baseline titers on serological diagnosis. So we need to rely on culture or antigen detection of PCR, though it may be costly or not available always. It is always important to repeatedly take history and do examination. It should not be that you examined your patient on the first or second day and forgot about it. Because in prolonged fever, sometimes new findings may come up after 2 weeks or 10 days. So we need to repeatedly go back to the patient to look for new findings. The etiology in many cases is an atypical presentation of a common disease rather than a rare one. And also, as I said, for confirmation, we often have to resort to invasive tests. So, thank you very much for your patient hearing.
Thank you very much, Dr. Nandini, for that excellent lecture. And with that, let's move on to the third speak today. Third lecture is going to be delivered by well-known speaker, Professor Panduka Karunanayake, who need no introduction to this audience. He is the professor in medicine, clinical medicine, Faculty of Medicine, University of Colombo. Over to you, Professor Karunanayake.
Thank you very much, sir, for that kind introduction. And good morning to all of you, ladies and gentlemen. My grateful thanks to the college for inviting me to give this talk. So basically, the task that was given to me by Kumudini personally was to talk about rational use of antibiotics. And the fact that I'm standing here does not necessarily mean that I'm a rational man, but I'll try. But to start with, why bother? There are several reasons why we must be careful about prescribing antibiotics. One is that they are among the commonest of the medications that we prescribe. They are also among the most powerful lifesavers and also relievers of suffering and disease. And they also enable other forms of therapy to be carried out which are otherwise impossible, such as, for example, certain surgeries, immunosuppression for kidney for transplantation, or immunological disorders, suppressing immunity for treating immunological disorders, and so on. These things won't be possible if not for the fact that we have antibiotics. So we have to protect them. But they also need to be used correctly and cost-effectively. And of course, the most important reason nowadays is that we must prevent or delay the emergence of antimicrobial resistance, or AMR. So basically what I'm going to do in the next 20 minutes or so is to offer a 10-step practical approach to using antibiotics rationally or optimally. Of course, you won't have to do all these 10 steps in every patient, especially if you are not going to prescribe antibiotics at all. But the goal of having these 10 steps is to make sure that we produce the maximum possible benefit, prevent misuse, keep the costs down, and also prevent antimicrobial resistance from emerging. So let me take you through the 10 steps one by one. First one, I have to say that I was very pleased with the previous two speeches, because this first step was brilliantly emphasized by both those cases, because both of them spoke about the importance of thinking about the clinical syndrome, something that we really need to keep in mind, because there's a tendency to jump from symptom to investigation, like chest pain, troponin I, and fever, urine culture, and so on. So we have to resist that, and the middle part between your symptom and the investigation is identifying the clinical syndrome. So that's the first step. Don't jump into grasp an infection as your diagnosis, but instead think about what clinical syndrome are you dealing with. This will help to ensure that we don't forget the full range of infectious disease differential diagnosis as well as the non-infectious differential diagnosis. So there's this lovely article which is quite old now but still very valuable in the Medical Clinics of North America. It sort of listed out some examples of this. For example, you may think of somebody as having a UTI. Don't think UTI. Think voiding symptomatology or dysuria frequency syndrome. There are other differential diagnoses such as urethritis, vaginitis, prostatitis, kidney stones or bladder stones, urethral syndrome, and so on. Similarly, somebody with fever, some cough, and some chest texture opacification, one might jump into the conclusion of pneumonia, but we should not do that. We should think of it as just as a syndrome of fever, lung symptoms and signs, and an opacity in the chest X-ray. So there may be some other differential diagnoses such as pulmonary embolism, pulmonary hemorrhage, vasculitis, eosinophilia, Mendelssohn syndrome, and so on. So this article went on to give other examples like what we might sometimes call meningitis or cellulitis or intra-abdominal sepsis or gastroenteritis or septic arthritis, and gave a wider differential diagnosis just by not grasping it as an infection to start with out of habit, but rather taking a step back and thinking of a possible clinical syndrome, because that gives you the full spectrum of differential diagnosis. Okay, so once we have identified the clinical syndrome, it has infectious disease differential diagnosis and non-infectious disease differential diagnosis. Both are there. Some can be non-infectious, like for example, what looks like pneumonia might actually be eosinophilia due to a drug reaction. So the next step, therefore, is to actually verify whether there is actually an infection going on. And the interesting thing is, positive microbiological tests such as cultures and serology do not always indicate infection. They may indicate a contaminant or a transient colonizer, such as what you often find in urine cultures, a normal flora, or a past infection, in the case of serology, for example, or of course, it might indicate current infection. So you see that current infection is only one of 5 possibilities when a culture report is positive or a serological test is positive. So our task is to first of all determine, is it actually an infection? Is it number 5 or something else? So don't jump into the conclusion that there's an infection just because the culture is positive or the antibody test is positive. And the interesting thing is to identify if the cause is actually an infection. Non-microbiological investigations are actually more useful. For example, the full report. If you're sending a sample for culture, you must send for full report and culture, whether it is CSF or urine or stool or synovial fluid or whatever, because the full report tells you that there's an infection going on because of pus cells and so on. And if an infection is actually going on, then the culture will tell you what the possible pathogen might be. So the full report is more important. Similarly, there are other investigations like the white cell count, the CRP, and sometimes even imaging might be helpful to determine that there's an infection going on to start with. So that's an important question. Is there an infection going on? That's the second step. Third step is, if you think that an infection is actually going on, which organisms are likely? Now that depends, that's a 3-step process. First of all, go back to the clinical syndrome. What is the clinical syndrome? Because this gives you, as I told you earlier, the infectious disease differential diagnosis. And the next question to ask ourselves is this infection an endogenous infection or an exogenous infection? Because endogenous infections are also very important. They come from our own flora, such as, for example, the skin, the oropharyngeal flora, the GI tract, and the urethral or the lower GU tract. So that's the first thing. Remember, think of the clinical syndrome and try to reimagine your infectious disease differential diagnosis. The second question is, what is the pathological response the patient is mounting against this pathogen? That comes from history, examination, investigations, all put together. When I say investigations, I'm talking about non-microbiological investigations like hematology, biochemistry, imaging, pathological tests like cytology or whatever, and so on. So I could sort of list out 6 possible pathological responses that we as human beings put up against infections. There is the famous acute pyogenic inflammation we all know about with high fever, neutrophil leukocytosis, and so on. It can be chronic inflammation, like, for example, what you see in tuberculosis, with anorexia, weight loss, high CRP, and so on. Then there can be a response to hematogenic infection, where the patient gets a more subacute infection, like a slow motion infection with splenomegaly. Then it can be a response to a low virulence pathogen, where the patient is not having a high fever, the CRP is only slightly high, but the infection is going on and on. Or it can be an intracellular pathogen, such as tuberculosis, brucellosis, and so on, with a chronic fever and increased gamma globulins and so on. And of course, it can also be a response to a metazoan pathogen, such as, for example, strongyloides and so on, where you clearly see a eosinophilia. So you can see that there are several possible pathological responses that we as human beings mount against various pathogens. So if you can identify which pathological response this patient is mounting against this pathogen, you can sort of get an idea about what the pathogen is. Is it a virus or a bacterium or a fungus or a protozoan and so on? And the third question is, Now that you have an idea about what kind of pathogens we are talking about, out of those pathogens, which ones was the patient at risk of getting acquiring? It can be a community-acquired infection, which is, in that situation, it's very important to look at the social and occupational history. Or it can be a healthcare-associated infection, where we have to look about the hospitalization history, any medications we have given, any infusions, devices, any recent hospital outbreaks, and so on. So this is how we get to the likely organisms. First question is, what is the clinical syndrome, which tells you the organ or the system involved? What is the pathological response, which tells you the pathogen spectrum? And from that spectrum, what was the patient at risk of acquiring, which gives you a short list of likely pathogens. Of course, some clinical syndromes actually give us a pathognomonic pathogen. For example, chickenpox, scarlet fever, impetigo, and so on. So in that case, of course, there's no need to go any further. We know exactly what medication or antibiotic to start if you find that the clinical syndrome itself is pathognomonic of a certain pathogen. So if you have this short list of pathogens, possible likely pathogens in your hand now, then you go on to the next step, what specimens to take. So making a laboratory diagnosis is particularly important in serious infections or when the differential diagnosis is very wide, like for example in reduced cell-mediated immunity, or if you have to start prolonged therapy, like for example for melioidosis, or if it's toxic therapy, like for example we have to start amphotericin for fungal infections. So in those situations, we must be very careful to get a good microbiological diagnosis before we start infections and commit the patient to that kind of therapy. And remember that as the clinicians, the lab report is only as good as the specimen. So the microbiologists have a certain say, garbage in, garbage out. If you send a bad specimen, you get a bad report. So the report is only as good as the specimen. So liaise with the microbiology laboratory as often as possible, except when the recommended practice is something that you are very familiar with. So you must be very familiar with which container to use, what is the specimen method, collection method, how to fill out the request form and what information to give in that, and how to transport the specimen. It's fully worthwhile talking to the microbiology laboratory to find out the answers to these questions, at least the first time that you are sending that specimen out. Sometimes, of course, we don't need a microbiology diagnosis at all. For example, in cellulitis or a community-acquired UTI or an acute uncomplicated gastroenteritis, which you don't think is cholera, you don't need to send any specimens at all. You can just start the treatment straight away or not start any treatment. So now you have taken the specimens and then sent it away. Next question is, are antibiotics necessary? Now, they are necessary only if it is likely to be an infection and antibiotics are known to improve the outcome. You can give antibiotics in one of three settings. One is empirically, where you take the specimens and start antibiotics because you don't want to wait. Or on a presumptive diagnosis, where it's not just the presentation alone that you are depending on, you have some kind of objective evidence like a ESR, CRP, X-ray or whatever, so you are closer to the diagnosis, therefore it's a better diagnosis or a narrower diagnosis, but it's still only a presumptive diagnosis. And the third situation is when you have a definitive diagnosis where the microbiologist has given you an exact diagnosis. Remember, a definitive diagnosis comes only when you have fulfilled certain specific microbiological criteria. Any culture report is not definitive. It must have certain specific microbiological criteria. So if you want a definitive diagnosis, it's very important that you yourself try to familiarize yourself about what these specific microbiological criteria are. And the problem, of course, in Sri Lanka is that we can't fulfill this criteria very frequently because we don't have facilities enough. There are other situations of treatment also, for example, prophylactic and preemptive therapy, which I won't talk about because I think it's a bit beyond my talk today. So that's the first question, are antibiotics necessary? Sometimes it's important to start immediately because of emergencies. I have listed some important examples here like septic shock, toxic shock syndrome, immunocompromised emergencies such as febrile neutropenia or hypocomplementemia and hyposplenism, acute pyogenic meningitis, necrotizing fasciitis, acute or hyperacute melioidosis, ecthyma gangrenosum, and meningococcal or gonococcal sepsis. So basically, these are the conditions where the patient can actually die right in front of your eyes. So there may not even be enough time for you to take specimens if that is going to take a long time. It may be even justifiable to just stabilize the patient and start the antibiotics straight away. So those are clear-cut examples of empirical therapy. Then there are other important things to do with infections also. For example, surgical treatment, draining suppuration, amputating gangrenous tissues, relieving obstruction, removing or replacing infected foreign bodies or devices, which are nowadays very common, especially things like dialysis access and so on. Adjunct therapy such as glucocorticoids, colony-stimulating factors for neutropenia, IVIG for hypogammaglobulinemia, and so on. Stopping or withholding immunosuppression for a while, and sometimes also probiotics. So these are some non-antibiotic therapies we must also take into consideration when you are also asking the question, are antibiotics necessary? So I put that as 5A. Then, now you have decided that they are necessary. Okay, then in that case, step number 6 is, if so, which antibiotics are necessary? Now that depends on the likely pathogens and their recent local antimicrobial sensitivity patterns that you know, especially important for healthcare-associated infections. And the site of infection is very important because antibiotic penetration to different sites will be different. You know, there are special sites like the CSF, ocular fluid, abscess cavities, prostate, and so on, which need specific antibiotics because the penetration is very selective. Local antibiotic guidelines, availability, practical issues. So like, for example, you want to give it oral or IV, whether you want to give it once a day or thrice a day, cost, and finally, very important for us nowadays, quality. So you will have a list of antibiotics now in front of you, which seem to be okay for this particular pathogen, this particular site, guidelines, and all those things. So out of this list of antibiotics that you have got, which ones are you going to give you to the patient? And that depends on step number 7. What about the patient or patient factors? Age is important, the very young and the very old. Pregnancy and lactation, partly because of contraindications and also because in pregnancy, antibiotic washout by the kidneys is faster. A history of allergy and intolerance, genetic variation, such as, for example, G6PD deficiency or slow accelerated status. Unfortunately, this would have been one of those areas where the concept called pharmacogenomics would have been very helpful, but over the last 20 or 30 years, pharmacogenomics has turned out to be a kind of like a broken promise. Although it was thought of as being very valuable at one point, it still hasn't been able to give its full potential out. Look at the patient's comorbidities such as renal, hepatic, cardiac, neurological, and hematological comorbidities. Can the patient tolerate oral medications? Is the patient vomiting or having diarrhea? Are there important interactions with food and other medications? What about the patient's lifestyle and side effects? For example, the famous photosensitivity with tetracyclines. And if the patient has to pay for it, what about affordability? So these are the patient factors that you must look at in step number 7. Step number 8 is, you have chosen your antibiotic now based on those factors and the patient factors. Now you must decide about dose and frequency and route. There are time-dependent antibiotic killers and as well as concentration-dependent killers. Basically what that means is that some antibiotics kill the bug better if it is in the serum for a longer time. That's called time-dependent. Whereas other antibiotics kill the bug better if the concentration is high. That's called concentration-dependent. So examples of time-dependent ones are beta-lactams and vancomycin. That's why we give them as, for example, we give meropenem as an infusion and vancomycin as an infusion because you give it over a longer period of time. On the other hand, examples of concentration-dependent ones are aminoglycosides or fluoroquinolones, metronidazole, and daptomycin. So we give them as injections, not as infusions. Sometimes therapeutic monitoring is very important, but unfortunately we don't have that facility in Sri Lanka. After starting, we may later be able to scale down from broad spectrum to narrow spectrum once we have a culture report. But when you scale down, be very careful because we have to make sure that our culture report is showing the pathogen which is actually the culprit. You know, for example, sputum culture or a urine culture may be a contaminant or a commensal, not really the pathogen causing the pneumonia or the pathogen causing pyelonephritis. So before you scale down, be very careful to be certain that we are actually dealing with what's called the culprit pathogen, just like the culprit lesion on an angiogram. And sometimes we can give oral because some antibiotics have excellent oral bioavailability. And after a few days of IV therapy, we might be able to switch down to oral, especially because if the condition does not require mandatory IV therapy, such as meningitis or endocarditis. Otherwise, of course, we have to continue IV, and then the question arises about how to get that IV access, which is very difficult in our country. Overseas, of course, we have what's called OPAT, which stands for Outpatient Parenteral Antibiotic Therapy, where the patient goes home with a line, and the nurse comes home and gives the injection. So that's about step number 8, and now you start the antibiotic. And then comes step number 9, is it working? So that depends on your assessment of certain parameters, which may be clinical or laboratory. The important point there is to try to decide on these parameters before starting antibiotics and try to use a combination of parameters. And remember that clinical parameters improve faster than laboratory parameters, except for the CRP. There are some situations where the parameters might actually paradoxically worsen even though the infection is getting better. I have listed them out here. For example, in pneumonia, if the patient was initially dehydrated, when you treat with antibiotics and also rehydrate the patient, the chest X-ray opacity will actually worsen. In the case of meningitis, before the dexamethasone era, when you start the antibiotics, the CSF cell count actually increased. So there are some situations where there can be a paradoxical worsening. There are also possible reasons for apparent failure, like giving the wrong antibiotic, or situations where it's useless, or superadded other second infections, or superadded non-infectious complications like DVT or drug fever, or surgical complications like suppuration, or the patient is immunocompromised, or the wrong diagnosis like it could be vasculitis rather than infection, or sometimes rarely a paradoxical response. Finally, step number 10, when to stop. Again, depends on the parameters, but we always try to err on the side of a lengthier course in the case of immunocompromised patients, especially hypogammaglobulinemia and neutropenia, and also if the patient is a very high-risk patient or the pathogen is a very high-risk pathogen like, for example, Staph aureus. So I'm sorry I had to sort of race through the talk in 20 minutes. So these are my 10 steps to help you decide how to use antibiotics optimally. Thank you.
Thank you very much, Professor Karunanayake. So in the interest of time, we can take one question from the speakers.
While waiting for the questions from the audience, can I ask one question because we are short of time? And all three speakers, mentioned about the syndromic approach in acute as well as prolonged fevers. And that's a very important category that I think in India this is being widely practiced, I suppose. But from the postgraduate point of view, Professor Karunanayake, can you tell us how we are going to implement this thing in practice, especially with regards to postgraduate training? And
so you want me to talk about the syndromic approach? Yeah, okay, fine. No, basically what I try to say is that probably because we have large numbers of cases in our wards and we have to, what's called crowd clearing, we tend to jump from a symptom to an investigation. I think what I would like to suggest is to apply your brakes there and not think about the investigation. The moment somebody has dysuria, we think of urine pyelonephritis or cystitis and start taking the culture. And of course, the full report has pus cells and some bug, so you think it's pyelonephritis. It's a self-fulfilling prophecy. Similarly, fever, bit of phlegm, okay, that must be pneumonia. So without doing that, let's just take a fuller history and do an examination, do some initial investigations, and try to come to a syndromic. All these syndromes don't have names, like yes, Cushing syndrome and so on. What it means is it's a combination of symptoms and signs and some initial investigations which you are very familiar with, like a pattern, which has a certain differential diagnosis. Some of these are infections and some are non-infectious. So if you apply your brakes and spend some more time initially at the first presentation of at the patient first consultation, I feel that we will really consider all that differential diagnosis. Yeah. And then we will not be starting antibiotics for the wrong reasons or starting the wrong antibiotic in the first. That's basically what I meant.
Yeah, thank you very much. And
so I think that concludes our first symposium of the day. A very interesting symposium on tropical infections. So let me thank all the speakers for their valuable contribution, as well as the two speakers from India for coming all the way. And let me invite Dr. Uluwathage to hand over the certificate of appreciation to the speakers.
Thank you very much.